Welcome to the Sibo Doctor Podcast with Dr Nirala Jacobi. If you're a practitioner and want to learn the basics of Sibo, head over to sibotest.com and sign up as a practitioner. This will give you access to a free 90-minute webinar on the fundamentals of Sibo treatment. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacobi and the Sibo Doctor Podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a Sibo case very confusing. I believe that by understanding the often complex interconnection of Sibo with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening. Okay. Welcome Sibo practitioners. Today I have with me Dr. Farshid Rahbar, who is a holistic and integrative gastroenterologist in Los Angeles, where he's the medical director at the LA Integrative Gastroenterology. He practiced traditional gastroenterology until 2006, when he realized the need for bringing a functional model of care into his GI practice. In 2007, he completed the integrative medicine training and obtained ABIHM status. He then completed additional training in anti-aging, functional and regenerative medicine, and achieved board certification through A4M. He then completed additional training in functional medicine through IFM, Institute for Functional Medicine. In 2013, he realized the potential for Lyme and Tick-Borne diseases, presenting primarily with GI manifestations. This immediately opened the door for further learning, the first of which was ILADs basic training in October 2013. By December of 2014, his practice had seen over 100 cases of Lyme and/or TBD or Tick-Borne disease presenting with GI manifestations. This experience in his practice over the last several years has emphasized the role of infections, acute and chronic, in causing ongoing GI-related conditions and symptoms. Dr. Rahbar has significant interest in areas of dysbiosis, Sibo, leaky gut, and measures that help these conditions. Like many other experts, he believes that the integrity of the GI system is crucial to the start of treating Lyme. Thank you so much for joining me, Dr. Rahbar. It's just been such a pleasure to also see your presentation at the Sibo Symposium.
Thank you, Nirala. I really appreciate this invitation. I truly feel honored, and I'd like to give my greeting to all those physicians in Australia that may be possibly listening to this presentation tonight. I hope we see more collaboration with physicians in Australia.
That's great. That's really welcomed invitation for that, because as we discussed before I started hitting record, in Australia the official position is that there is no Lyme disease. And that's really unfortunate because as integrative physicians and practitioners, we often see very much classical Lyme presentations in our practice. But I'm not really a Lyme expert, and so I'm just delighted to have you on the show so that I can ask you a whole bunch of questions that I've been meaning to ask you since I saw your presentation at the last Sibo Symposium in 2016 in Portland, where they gave you only 15 minutes for a presentation that looked like it would take an hour, if not an hour and a half. So moving right in, how did you, just before we get into the meat of the matter, but as a gastroenterologist, I mean, you're basically like a unicorn in the field. You're so rare, a gastroenterologist that is focusing on integrative medicine, and then with a specialty in Lyme. How did that come about?
There are two parts into this. First was the idea of bringing a functional model into the GI practice. And as we evolve in life, we learn that at one point what we're doing may not be sufficient for our patient population. I remember back in 2005, 2006 that I was primarily writing prescription drugs, and I just felt intuitively that something was not right. Eventually, I came across a patient who had an orthostatic hypotension and had seen two neurologists, two cardiologists, and couldn't understand what it was. And it turned out that basically that particular case was a low B12 on the borderline for that individual was too low. So from there on, I decided to go and study this area of nutrition and hormones and anti-aging further. And the first one I did was to get my board certification in integrative medicine with the Scripps Clinic. That opened up a whole can of worms, and I just realized that there was a lot more to learn. And after a while, I became a conference junkie, going from one place to another. And almost every month, I was in one part of the country listening to the lectures, making notes, and eventually with the idea of bringing this under one roof and see if we can make that as an add-on to the GI practice. So there was a lot of effort involved to create a connection and a model that was not entirely there before. We're very proud that we're 10 years out and we continue as a student to learn in this field.
It's so fascinating. I mean, I think all of us listeners can relate to the conference junkie aspect, because anyone who is interested in especially functional digestive disorders, this is just the best time right now in research and in medicine to be involved in that, because there's so many revelations coming fast and thick, it seems, a lot of research into the microbiome and so forth. So it's been really interesting to follow all that as a naturopathic doctor. Now, can you, not everyone that's listening is really familiar with Lyme, and I don't want to make the show just about Lyme, because I want to really look at Sibo and Lyme and how those two overlap, or what are the presenting symptoms. But firstly, can you, just for those listeners that aren't really familiar, just give us a quick primer on Lyme disease?
Well, first of all, we actually had to evolve into this, and it was rather passive. Back in 2012, 2013, I suddenly came across three patients whom they had Sibo, and we kept treating them, and they had IBS type symptom. They go from diarrhea, constipation, I'm fatigued, I'm tired, I'm mentally foggy, I can't work. It doesn't matter what we did, it just looked like we're going from one place to another without getting a major achievement. One of them eventually was diagnosed with positive Lyme markers, and it kind of put me on alert. Another one was a patient of mine with actually a fungal overgrowth, not a Sibo, but a CFO clinical picture, and she had gone under my care to the emergency room 2 times with paresthesias on her face, and she had seen neurologists. They said there's nothing wrong with you. She had palpitations and had seen a cardiologist, and they could not really understand why she was having these rapid heart rate episodes without any explanation for some reason, age 30, 32 type of range. And there was another guy we had from Wisconsin who really was having IBS type symptoms, was referred by another GI doctor. There was 4+ fungus growing in the stool, and also there was Sibo with methane present. And I eventually said, well, let me order some of these Lyme and Tick-Borne Disease markers for you through a regular lab, and his Ehrlichia came back, positive. So then Lyme markers were also positive, but it wasn't your typical, criteria that you see to call it, an active Lyme disease. But it was obvious that he was exposed, and more importantly, what the patient said was, look, when we were kids, we just played with these ticks. We thought it was fun. And they were playing in bushy areas, and they took these things off their neck and their bodies. And then he reported to me that he had recurrent sinus infections, and for years he was taking antibiotics. So it's possible that, for years he was suppressing a chronic infection, and eventually it picked up momentum and it caused some sort of autonomic dysregulation and inability to keep the gut clear, perhaps some autonomic neuropathy into this, and end up with the phenotypic presentation of gut dysbiosis, but that's what really was not the primary problem. And we keep trying to fix that, wouldn't address the underlying scenario. From there on, I immediately took the ILADs training, and I became more familiar with how to order the test and understand the clinical picture. And we started to do testing, and that opened up a can of worms, because we saw patients from all over the US coming, and the clinical scenario was so repetitious that I can almost tell you, after a few months, my secretaries could almost see which patients may have actually a chronic tick-borne illness. And I don't want to use the word Lyme only, because now I understand that not everybody has borreliosis, and even under that term, there are so many subspecies that, it's not just, Borrelia burgdorferi causing Lyme disease. There are other subspecies that may have similar clinical presentations. Unfortunately, the testing model is expensive and is not completely accepted by all the universities, and that has created a scientific battle, between one group that is more traditional and another group that it's more associated with ILADs, and the European, educational committees that believe in the ILADs work. And the ILADs is standing for the International Lyme and Associated Diseases Society. And currently I'm a member of that, and I participate in the educational committees, and I can see the challenges that go behind the scene to create a definition of chronic Lyme. If you look at the textbooks, acute Lyme is described. There is no such a thing as chronic Lyme disease. So first we have to get over that hump. Until then, I encourage clinicians to read about this and realize that such entities do exist, and it does require that we become familiar with that. Otherwise, they will have patients that they will have unexplained symptoms and chronic inflammatory conditions that are unexplained. In the next few months, we will be presenting clinical pattern recognition as how these tick-borne illnesses may actually be presenting based on what we have seen in our practice, and hope that at one point somebody's attention will, come into the view and they take this to a more research level.
So will you give us a sneak preview as to perhaps as to what you'll be presenting on in terms of what are the core sort of clinical presenting symptoms that you see in your practice with not just Lyme but co-infections? Or is that too much of a Pandora's box to go into?
It is a little Pandora's box, but generally speaking, when you look at a presentation, a patient comes to the office with digestive symptoms, gas, bloating, fermentation syndrome, altered bowel habits, but there is generally a component of fatigue and also neurological component into this. And I think if a physician sees those, they need to be on alert that this may be more than just a simple Sibo. If you see a female, and I say female because almost 80% of our patients here in Los Angeles, they have been Caucasian females. And there seems to be a predilection for the genes from Europe to have a susceptibility to these type of chronic infections. So when I see a constellation of energy issues, mitochondrial dysfunction, a Sibo condition that it's not easy going away, patient has seen multiple physicians and they have tried different things, and there seems to be an immune dysregulation. Joint pains, stiffness, cognitive dysfunction, memory-related issues in a young person, and bladder-related issues with urinary frequency, abnormal sensations and skin manifestations in the form of sensory issues that they're not explained, one has to be on alert that they may be dealing with an underlying tick-borne illness. And that's really a capsule of what I wanted to mention from a symptom point of view. Then there are also conditions that one will see. We're not talking about symptoms, we're talking about conditions. For example, you see somebody coming using medical marijuana in a young age, and you ask them, are you using recreationally? And they said, no, I use medical marijuana because I feel better. Why do you have that? I have anxiety. Well, what is the reason for anxiety? I'm not sure. Okay, I'm not having under any unusual stress or school-related issues or work, but I feel constantly anxious. And generally like that, my interpretation would be that this is a manifestation of inflammation, that the brain cells are probably surrounded by cytokines that create anxiety that is unexplained, and the person is using a medical marijuana to calm it down. Or they feel a little bit better because the body is not so achy. Why would the young person have an achy body? And again, when you look at these scenarios, one needs to think beyond the surface and see if there's another infection maybe sitting in the background. Also, we had recently 2 well-documented cases of hypochlorhydria. 2 women in their 30s, maybe less than 40, positive anti-parietal cell antibody positive. We documented hypochlorhydria using Heidelberg test, classical manifestation as far as the tracing that we got in the study. And the question is that why is an autoimmune dysregulation, whereas the vagus nerve and the nerves coming to the stomach are not stimulating the stomach enough to create acid, as if that cycle is broken. And my theory was that there's inflammation around the nerves provoked by another infection that is causing this. Both of these 2 patients turned out to have Bartonella, and they were both well documented based on the antibodies that came back. But once we saw the first one, the second one was easy because I could almost predict what to look for.
Can I ask a question about that? Because that's really interesting. So you said that both of those patients did have positive antiparietal cell antibodies?
Yes.
Yeah. So how are you saying that the Bartonella triggered some sort of autoimmune response that then ended up the patients being positive for these antibodies?
Absolutely. So there was evidence of immune dysregulation and evidence of neuropathy because the acid was not produced. So what we did an endoscopy and biopsy, and there was no gastric atrophy. The cells were there. I don't think they were receiving the proper signal to produce the acid. So the theory that I raised was that there's neuropathy behind this, means that an autonomic neuropathy for the vagus nerve and its branches, to stimulate the acid production. And the question is that why would somebody become like this? Both of those patients had exposure to, cats. They had either cats at home or they had it at one point in their life. And there were some energy-related issues and other things. They were not functioning at their best, but the clinical presentation was one as hypochlorhydria and a pernicious anemia type picture without having, the old classical symptoms, if you will.
Which leads me sort of to my next question of, what's the connection between Lyme and you mentioned in your presentation before that there is sort of you do see quite a bit of overlap of Sibo and Lyme. and just wanted to kind of get your take on what's the connection. I'll ask you definitely more questions about the vagus nerve a little later on when we talk about dysautonomia and small nerve fiber dysfunction and destruction, really, that you've talked about. Very, very interesting and very important aspects of how things could correlate with Sibo, but I just wanted to kind of see why people are maybe more susceptible, or have you seen that they're more susceptible to Sibo if they also have a chronic infection?
Well, in our practice, obviously, by the time the patients get to us, they're generally more complex. So I'm going to speak from what we have seen and our own experience here. 65% of our patients who eventually we diagnosed that they had clearly positive markers of Borrelia burgdorferi, or at least one of the other tick-borne illnesses. They had the Sibo. And a portion of those also had methane. And the methane production, when we looked back, it appeared that, it didn't follow the usual pattern that you see with hydrogen production, and the patient might have had a food poisoning and having a vinculin antibody. The methane producers did not follow that pattern. There was another reason for immune dysregulation and being more susceptible to infections. So the connection with the Lyme was the fact that there were many patients presenting with bloating, gas, fermentation syndrome. Many of them had positive Sibo, but it wasn't one of those cases where you just treat them and they just go away. You required multiple treatments, and when you go to the review of system form, you can see they have multiple, symptoms circled in different parts of the body, from the same thing I mentioned, from a neurological part, from joints, from energy issues, from allergies, food sensitivities. It wasn't more than just the Sibo. And if you treat the Sibo, you're really not just completely resolving the problem. They may get some improvement in the in their fermentation symptoms, but many other symptoms continue to remain in the background. And that's when we need to think about that the Sibo may be a phenotypic presentation. It just may be the tip of the iceberg, and it's telling you there's another condition going on in the background. And some years ago, we had simpler cases of Sibo, and they come, there was no other condition going on, you treat it one time and the patient is very happy and they go away, you put them on some erythromycin at bedtime, and they probably will not have another recurrence for several years. We're not seeing that pattern anymore. Okay? Our Sibo cases are much more difficult to treat, and occasionally I've actually turned around and said, you know what, instead of focusing on your Sibo, we're going to have you go and get the underlying problem addressed, and we'll come back and readdress the Sibo after your immune system is improved. Please let me know if I did not give an answer to your question.
Well, it's all good answers. It's all important information. I'm just thinking of our, the average listener and Sibo practitioner out there, whether they're a naturopath or an integrative GP or a specialist. What can we do, or because I know that testing, perhaps it's improved, but what I know about the testing for Lyme and co-infections is that 50% positive at best, right? So 50% chance of actually catching it if it's there. Is that still sort of the percentage of the testing coming back positive, or are there better things to test for, and how can we help to diagnose some of these perhaps undiagnosed cases of Lyme and co-infection, and then refer on to specialists or something? I'm just trying to think of the average practitioner out there. How can we help them out to help diagnose this a bit more?
Well, I am not sure if it's wise for a practitioner who has not studied this area to start doing a lot of testing, because the area is controversial, is heated. I know the same exists in Australia and Europe and in US. And Unless you're well studied in this area, it would be somewhat challenging. You can order regular testing through your regular labs, but I am sure both in Australia and in US, there are specialized labs that they offer those extras, if you will, to make the diagnosis easier. There is definitely a need for clinical correlation. We have had patients with clearly positive Lyme markers, and they feel fine. So it's not about the test. It has to be correlated with the clinical picture. It is really about the balance of the immune system as how it is controlling this chronic infection. The reality is that from what I've learned, that our bodies may not be completely sterile, if you will. And there may be not only Borrelia or other bacteria, there may be other viruses and mycoplasma, chlamydia, other things in there that the immune system is handling it, so we don't really feel a clinical presentation. So the first thing is that to be able to understand how possibly these things can present. In a Sibo context, if you have a patient that comes with bloating and gas, IBS type symptoms, but their associated conditions, particularly energy related issues and cognitive issues in a young person, a rheumatological type picture, a urinary symptom that are unexplained, one has to be on alert that there's a problem. And it may be more than just what we see as a Sibo. We can still try to fix the Sibo, but if the symptoms do not go away and the problem continues, at least discuss with an expert who is familiar and is Lyme or tick-borne literate in making recommendation for additional testing.
And then additionally, I would say that, nowadays, we also have this potential for mold exposure and mycotoxicity, which can also trigger chronic inflammatory response syndrome, which is very much like Lyme, like a Lyme presentation. So it's becoming a little bit harder as a practitioner to kind of tease out, if you will, Lyme symptoms from mycotoxicity to chronic immuno issues and activation and Sibo. So this is why I'm so appreciative of your expertise in this area. And I'm not sure if you would agree with me about the chronic inflammatory response syndrome, but that is something that also seems to be sort of center stage with a lot of integrative practitioners these days.
What you mentioned is absolutely true and is consistent with our own experience here. Indeed, I am one of the fans of the work that Dr. Shoemaker has done in this area. And I know that one of your colleagues in Australia has worked also with Dr. Shoemaker in creating a Lyme literacy website for patients and doctors to review. A mold literacy website to make patients and physicians familiar with this concept. Mold exposure and Lyme or other tick-borne diseases, they seem to go hand to hand. It appears that one might have been, for example, exposed to Lyme bacteria, and maybe the condition is under control until a risk factor comes up, such as excessive alcohol consumption or excessive sugar, or being under a lot of stress or lack of sleep, or being exposed to a water damaged building with presence of mold in that area. Apparently 25% of the population, they carry a genetic profile that makes them more susceptible to the biological toxins that they come from mold. And we have been looking into this, and sometimes when we cannot explain an immune dysregulation based on a tick-borne disease, we have looked into exposure to mycotoxins. And I really think they go hand to hand. And many times Lyme literate physicians, they need to also be familiar with biological toxins from environment. And a common one would be exposure to mold in the environment. So if somebody is living in an area that may be damp or there has been water damage to the building, they may be quite susceptible to being exposed to these type of spores and microbes. As part of our work, we have done now nose cultures. A lot of our patients have expressed nasopharyngeal type symptoms, and we have seen very interesting findings on nose cultures. And I'm almost starting to develop an idea that perhaps a postnasal discharge at night, it may be a risk factor for dysbiosis and Sibo by constantly feeding a sensitive gut area in a susceptible individual.
So you're saying that the postnasal drip or the mucus, patients are swallowing it and therefore creating sort of a lower dysbiosis?
Yes, I mean, like that's
interesting.
That's the association. I mean, I'm not saying that I published this information, but I mean, it's becoming such a common finding. A lot of our patients have nasopharyngeal symptoms. They're chronically living with it. They come with GI manifestations, and they may have SIBO or C4, but when you start to look into their nasopharyngeal symptoms, many of them, they have major pathology there, but it's kind of a low grade, and they're living with it. And I have to speculate whether that becomes actually a source of feeding, you know, a bad balance of microbes into the gut environment, especially if there's hypochlorhydria, which many of our patients have, or they have immune dysregulation and they're weak for other reasons. And you basically constantly feed, you know, from the nose area into the gut area.
Well, I actually had a really interesting conversation with Dr. Scarpignato, who is, you know, the Italian gastroenterologist who is really an expert in rifaximin and other areas and Sibo, and he's actually in the process of publishing a paper on the oral microbiome and Sibo and PPIs and all that. And so it's my understanding that is really a crucial aspect for that to occur. What you've just described is that either PPIs or hypochlorhydria. And I could imagine a scenario where there is chronic perpetual infection if those conditions are there, where those kinds of overgrowths can really occur then if you're continually swallowing organisms that are infectious in nature. So that's really interesting. I think we have to wait for the research to really to kind of confirm our suspicions, but I do agree with that. I think that, I mean, you know, one of the things that I wanted to ask you about in relation to Lyme and mycotoxicity and stealth infections and chronic Sibo is that, it's sort of a theory of mine that us integrative practitioners are really realizing that we've never really faced such an assault on the microbiome before. We're in the midst of it, where we're seeing the microbiome, which is supposed to have about 4,000 different species, be decimated down to less than 1,000 in some of our patients, in terms of total species count, not total bacterial number, in terms of normal microbiome. And so that's what we know is people that come out of limited connection with society or with Western lifestyle have much more rich microbiome, and those that don't have far less species diversification. And I wonder if some of the immunity or immune issues that we're seeing, because I mean, we've always been around mold, we've always had stealth infect, we've always been exposed to, Borrelia burgdorferi has been found in the man that was in the ice that was thawing in Switzerland, that was thousands or 12,000 years ago. He was actually positive for Borrelia. So we know that these organisms have lived with us. And my theory is there a connection between the alteration of our microbiome over the last 50 years and what we're seeing now, which is chronic illness, autoimmunity, and chronic immune dysfunction?
Absolutely. I mean, I'm sure there's a lot more to learn on the microbiome and the reduced diversification. I definitely see that as a common problem in our patients. I'm not completely sure how we need to work around it. I mean, obviously, we do everything we can to bring the proper environment back, but that would be an area of discussion as what protocols one would use while the research is being completed in this area.
Yeah, I think FMTs or fecal microbiota transplants are coming, not fast enough, but they are. I think there's a lot of excitement around that as a potential for microbiome transplants, that kind of thing. But getting back into the Lyme Sibo conversation, you mentioned that you see often high methane levels in your Lyme patients. Any idea as to, like you mentioned, immunosuppression? Is that the connection as to why you see maybe more methane rather than hydrogen?
Yes, the methane to me, when I see it, is a phenotypic manifestation of immune suppression. So I start to look for causes. I mean, I can argue that one person may have a biological toxin exposure and may have issues with mycotoxin. Another individual may be highly stressed and might have gone through high levels of cortisol for a while. Another individual may have had very bad eating habits with fast eating, late eating, and basically not allowing to have active the motor migratory complex. And then some of our patients, when they have more cognitive issues, joint pains, and energy-related issues, that has brought up our concern about underlying tick-borne illness. Particularly when there's CNS symptoms or manifestations, we have very aggressively studied these patients to see if they have underlying stealth infection or hidden infection, a common category being the tick-bornes. And when I say the tick-bornes, there are usually 5 of these that are common: the Borrelia, the Bartonella, Babesia, Ehrlichia, and Anaplasma. But the Borrelia group, the group that particularly has more CNS manifestations, would be the Borrelia relapsing fever group. And some of the patients have had more involvement of that one when the Borrelia burgdorferi was negative. But clearly, if one starts to look into this philosophy that there is an immune suppression and we need to think about that, once you start to look, you will find causes. If it's not the usual common causes I mentioned, then one, in my opinion, should look into tick-borne illnesses, if you will.
Great tips there. One thing I was really fascinated about was in your presentation, you also mentioned Sibo, Lyme, and causing dysautonomia and small fiber neuropathy, which I'm hoping we can elaborate a little, but just to kind of connect it to the Sibo, you were also talking about GERD and loss of accommodation in the stomach and its relationship to dysautonomia. And just for the listener, one of the reasons why we see gastroesophageal reflux in Sibo patients is because of the fermentation causing gas and pushing the acid back through the pyloric sphincter and then through the lower esophageal sphincter. And so a lot of patients with chronic GERD, that's actually a risk factor for Sibo. But then when I heard your lecture, as it relates to chronic infection and causing nerve or neuropathy in the stomach itself, can you elaborate on that?
Right. It basically goes back to the concept of chronic inflammation and immune dysregulation, which has involved the autonomic nervous system. Now, we had a few patients who had on biopsy a small fiber neuropathy, the C fibers, and some of these are also similar to what's in the enteric nervous system. So once we agree that there is an autonomic component into this, then our vision is not just to look inside the lumen of the gut. We need to think about all the structures and the neurons that are outside, and what is the relationship of the gut with that one. Well, I don't think in the case of GERD, it is the gas that is producing the lower esophageal sphincter malfunction. I believe that the lower esophageal sphincter malfunction, it comes from two components. One, presence of cytokines in the small bowel, an infection that they travel through the blood and it relaxes the valve. Some of that has been shown in obese patients where they have abdominal obesity and they have high level of cytokines in the abdominal wall. The issue of the gastric accommodation, it has already been in the classical textbooks that the fundus does not relax properly. Well, the control of the fundus and the relationship between the esophagus and the fundus, the part that we call the angle of His, it is controlled by the autonomic nervous system. And if you look at some of the pictures by Frank Netter, you can see how beautiful the drawings show how the nerve fibers basically come and traverse that area. So there must be a lot of, crosstalk between the esophagus and the stomach to keep the angle of His in a proper shape. And I think once you have neuropathy, that balance is not there, and one will be dealing with lower esophageal sphincter malfunction, and that allows the juice to regurgitate into the esophagus. Now, in harmony with that, there's also the issue of bile reflux and presence of bile in the stomach. One sometimes can have normal stomach acid, but if the bile regurgitates into, if the bile regurgitates into the stomach, it is going to neutralize the acid and is going to behave as if there's hypochlorhydria. The main question is that why there is bile reflux into the stomach. Normally, the peristalsis should be forward going, and if it keeps coming back and the pyloric channel is open, then my theory would be that the body is sensing that the gut is not clean, and therefore it does not want to allow the food components to enter into the absorption zone. And that simply means that when we're dealing with bile reflux, we need to also focus on cleaning up the gut, whether it's C4 or Sibo or is parasites, and hoping that that will basically correct the bile reflux that is adding to the problem. Again, it's really a constellation of several things, autonomic neuropathy, dysbiosis, pyloric valve insufficiency, and bile reflux, and some of that leading to gastroesophageal reflux disease. And in any clinical scenario, one may see one or more of these combinations together.
So not just, so if I can clarify, the autonomic dysfunction or dysautonomia is more reserved for those chronic infections as in Lyme and co-infections, is that correct? Or do you see that also in Sibo? Sibo, just plain Sibo.
The autonomic dysfunction or dysautonomia has many causes. One of them would be Lyme and Tick-Borne diseases based on our experience. There are other causes described in the literature, and obviously if the issue comes up, one may have to get a formal neurological consultation to see if they can further define that.
That was my next question, is how is that diagnosed? How is the dysautonomia diagnosed? Is it through a neurologist?
Well, many times, one can get a sense of the symptoms, and a very beautiful review of this is already in, if you look at a simple place such as Wikipedia, it has such a nice review of the manifestations, and at least one can be familiar with the clinical symptoms. After a while, one will get a sense from the symptom presentation if there is a dysautonomia present or not. This is somebody with, periodic tachycardia, hypotension, POTS syndrome, and it will bring the idea that there's something wrong with the autonomic system. And if you want to investigate further, there's a whole list of tests to do And the only one that I found really easy to do in the office setting was the sweat test. The machine was, however, very expensive, and we tried it for some of our patients. It had maybe a 70% sensitivity, so it wasn't something we can easily include there. To investigate this further, I recommend that the physician works with a cardiologist who is familiar with autonomic dysfunction, perhaps doing a tilt test, or working with centers that they deal with this type of problem where they may have the machine for sweat testing and so forth. Okay. It's not a straightforward thing that you can do with a blood test or a quick test to get an answer. You need to have a clinical suspicion and then decide if you want to further investigate that.
I think you also mentioned gastroparesis potentially being as the result of dysautonomia. Is that correct?
Absolutely, Kate. I mean, gastroparesis in a young person, particularly that is not diabetic, I mean, this would be a prime target for me to investigate for Lyme and other tick-borne illnesses. Nowadays, when we order it, I generally order these as a panel because the more information I have, the better. For example, if I had a borderline positive marker for Borrelia, and I saw, for example, Ehrlichia or Anaplasma showing a clearly positive antibody, then I know this person has been exposed to a vector bite. And occasionally, as I said, you may have Borrelia group negative, but the relapsing fever group may be positive, which has more tendency towards the central nervous system.
Okay. Yeah, I have a few patients that have this loss of accommodation and gastroparesis on gastric emptying studies, and I have a high level of suspicion that they're exposed to tick-borne illness or tick-borne diseases. Just to kind of clarify also what you said about the lower esophageal sphincter relaxation through cytokine release, because this is something that obviously would also bear some clinical significance in erosive esophagitis and Barrett's potentially, or do you and as a follow-up, what kind of cytokine, are we talking about IL-6 and that range of cytokines very specifically relaxing the LES? Because that certainly would have a connection with Sibo.
Right. I actually have not been doing actual cytokine panels. I have been under the impression that a variety of inflammatory cytokines may have an effect, but is it really worth doing them one by one and see if we find a correlation? We order so many tests that finances become a challenge, so I have not expanded in that area, but from what I've read, I do believe that I don't think it's the gas pressure backup. I think it's more of a central effect through an inflammatory cascade that it causes additional relaxation. There may be additional cytokines in the esophagus itself locally, but that's not the one that I was referring to.
Right. More systemic.
Yeah, more of a systemic effect, which I believe it's actually originating from the gut itself, from a small bowel. And the same type of scenario in a woman can produce more premenstrual symptoms, more painful periods, more pelvic type of inflammatory manifestations, if you will.
Great. I guess I'd never really connected the dots of the actual inflammatory cascade being the culprit behind lower esophageal sphincter relaxation. That's important information in my little arsenal. So I stand corrected.
Question.
Yeah.
It's going to be reality, I think. Yeah.
Well, I've got a lot of patients with very refractory sort of GERD, so and of course we're working on all sorts of other things, but I think I got that from, I can't remember now who told me about the gas, because it made sense that if gas is very high and somebody is burping a lot, that there would also be some sort of regurgitation of acid, but I guess that was wrong information.
Well, the burping, if I may say, if the fundus is tight it actually is going to overcome is going to increase the pressure in the, it is gas, but it's not necessarily a gas regurgitation from a small bowel. I think whatever is in the stomach is being squeezed and it's going against the LES. LES sometimes when we look at it during endoscopy is very tight. You can see the lower esophageal sphincter is nice and tight, but the patient still has evidence of reflux esophagitis. The only way I can interpret that is by fundus being very tight and not having the proper accommodation, pushing the stomach contents into the esophagus and causing injury into the lower esophagus.
That's interesting. And also with methane, we know that that does cause retrograde motility and causes a lot more nausea and burping. And so I certainly see that clinically in my practice with patients that are very high methane on a breath test tend to have a lot more of that complaint. I know that you specialize in these very chronic diseases and chronic illness. Do you have any sort of clinical pearls, what you've seen works really well with your Sibo patients that we may never have not heard about?
I'm going to throw a few ideas and hopefully this will help. First of all, I think it's crucial for patients to eat slowly and chew well because otherwise we're not going to be able to win the battle. I also think it's crucial for them not to eat or drink anything within 2 to 3 hours before they go to bed. Sometimes they snack a little bit later, and that may suppress the MMC, the motor migratory complex. So again, we will be back to square one. Stress management, important. I mean, the treatment of Sibo, I don't believe it's just one more pill. Let me try this, let me try that. I think we need to think about this as a lifestyle modification and how a person is going to live their life. So stress management, proper eating habits, chewing well. We use a lot of souping because I think the food may already have the texture modification. And also we frequently use immune globulin, particularly the serum-derived immune globulin. I found it to be very helpful in management of the Sibo.
And what are those? Can you elaborate on those? Are these?
It's basically like colostrum, but it doesn't have milk in it. There are a variety of these in the market now that they call them serum-derived immunoglobulins. They have high IgG levels. And if you look at the stool analysis, sometimes you can see people with chronic Sibo, they may have very low SIGA level, or some of them, they may have high SIGA level. Either one is abnormal. The high one means that the body is trying very hard to keep the gut clean, and the low one I interpret as basically exhaustion, and it might have gotten to a point that it basically is not pumping enough of the immune globulin. So these patients, we prepare them with immune globulin. Most of my Sibo patients and CFO, we go through a two-phase approach. The phase one, I call it the preparatory phase, followed by an attack phase. And I don't usually go into an attack phase until we have done the homework on the preparatory phase.
So how do you do that? How do you prepare for the first phase? To kind of walk us through your program.
Again, you want to correct it as much as you can, nutritional deficiencies, stress management, their hormone imbalances. I mean, to attack it, dysbiotic flora of whatever is herb or rifaximin or neomycin and release a lot of endotoxin in a leaky gut, and many patients may feel worse because they can't handle the load of endotoxin release. So I need to feel that they have gone some degree of improvement and they're doing some of the basic elements and nutrient replacements properly before we can go into the attack phase.
I completely agree, and that's one of the reasons I actually created the biphasic diet or the biphasic approach, because it was way too much for a lot of patients just to go do everything all at once. So, we have an approach where it's quite restrictive, the diet at first, but you do a lot of gut repair. And then, and you're already starving the bacteria a little bit. And so after 4 weeks, you go in and you start using antimicrobials. And that's been really successful. Just as a follow-up to your serum-derived immunoglobulins, are you using the Symbiotics product? Symbiotics is like proline-rich polypeptides. It is, I can't remember his name. He's a doctor who formulated this. This is from bovine colostrum, but it's milk-free. Well, not milk-free, but it's basically pre-milk immunoglobulins and proline-rich polypeptides. Is that what you're using? Or, I mean, you're allowed to use brand names here because the more help we can get, the better. We don't have any financial interest.
Similar to that, yeah, I mean, some of the nutraceutical companies in US, like the Orthomolecular and Zymogen, they have IgG Protect, IgG.
Oh, yes. 2000, yep. I know which one you mean, yeah. Mm-hmm.
Right. But those are milk-derived, okay? Mm-hmm. And some patients, I mean, maybe infrequently, they may have an issue with that. There's also a different set of products in the market. The one by prescription in US is Enterogam, and that is has very good research. They even did some work on leaky gut, and I was very surprised that in the pamphlet and drug information material that they provided, they had actually had some information on leaky gut and tight junctions and how these things will improve. So there is, at least in US, there's a prescription version and a variety of non-prescription versions that we also refer to as part of our treatment. Some of these, they do have dextrose in them, so one has to take a little bit of a caution in case the patient has SIFO, small intestinal fungal overgrowth, at least clinically, and at least do some trial and error and see if it would be acceptable to the patient or not.
I actually just listened to a podcast the other day with Dr. Rao, who did a lot of research into SIFO. And in it, he mentioned that he hardly ever uses nystatin because it doesn't seem to make it through the stomach. But then there are those practitioners, myself included, who have a lot of experience with nystatin and find it to be extremely helpful in SIFO and lower bowel dysbiosis and fungal overgrowth. What's your take on, and do you use it?
I use nystatin quite frequently, and I found it to be very, very helpful in our patient management.
Yeah, great. That's what I thought, because I was just like, when he said it doesn't make it through the stomach, it's like, wow, people have massive die-off. How would that occur? But not to question it, it's just that we have different experiences as practitioners, so it's just really interesting to me.
Right, because classical textbooks, they have nothing written about these things. So it's basically anecdotal experience, but I would say probably 1 out of 3 or 4 women that comes to this practice has an issue with the yeast, and I find the nystatin to be helpful in their cases.
Do you use biofilm disruptors for Candida, or if you do use biofilm, I mean, also for Lyme and for Sibo, what do you use?
I do use biofilm disruptors. Generally, there's only one brand that I've used. There may be other ones. The biofilm that is used for Babesia and for Borrelia, those are designed, in my opinion, more so for intravascular biofilm. I don't personally treat Lyme and Tick-Borne Disease in our practice. It's just we don't have the resources to go that route. So we remain more focused on the GI system. But I know our colleagues who do treat, they use biofilm disruptors as well for the blood aspects.
Well, Dr. Rahbar, this has been so packed full of little clinical pearls that people can use. We'll have all of the information for your clinic and your contact details listed on the podcast website. Thank you so much for your time, and I really hope that we get to talk to you again in another episode.
Thank you for listening to the Sibo Doctor podcast. We hope you found the information in this episode useful in the treatment of your Sibo patients. Head over to our sponsor, SiboTest.com, an online testing service for your patients and home of the Practitioner Education Portal. Tune in again for another episode of the Sibo Doctor podcast. Thanks again for listening.